Okay, this better be good. Hello, everyone. Good morning, good afternoon, good evening, depending on where in the world you are joining us from. And thank you so much for choosing to spend this 1 hour with us. Trust me, this is the best decision you would have made for yourself today. My name is Mercy Juma. I am a storyteller, a journalist by profession, and a strategic communication specialist. And I'm so honored to be your moderator for the day. And again, thank you for being here and welcome to Real Talk. Now, let me start by telling you a small story. If any one of you has visited any of the social media pages for Align MNH, then you probably saw a question that, the wonderful people behind this whole webinar put there asking about, whether you are comfortable and how comfortable you are getting health advice from AI tools. Now, I asked this question to my mom. She's a midwife and she's 76 years old. And you know what she said? She paused and then she told me, okay, you know what? 95% of my trust, it's the nurse who knows my name. It's the community health worker who shows up at your door. And she says, those AI and chat GPT and all that, they don't sense my fear. They cannot hold my hand and squeeze it and say some stuff. And then I asked the same question to my niece. And these two are 50 years apart. Their age gap is 50 years. And my niece said, I ask Google or I ask my tablet and it answers very fast. And if it helps me get better, then why not? But sometimes I still want to get a doctor's check. Now, listen, this is why I'm saying this. Between that conversation, that small exchange captures the crossroads that we are in today, that we are standing in or at in global health. My mom's world is powered by people, 90%. My niece's world is powered by technology, and tablets and all that. But the truth is, for both of them, is that there are not enough people to give care to either of them. The workforce gap is not closing fast enough. We are not going to close it. And that's not why we're here today. We're not going to debate about that. We are here today to think about, if we can't close the gap, how do we reinvent the way care is given, trusted, and received? How do we blend human empathy with new tools, with AI, with telemedicine, with digital access? But also very, very important, how do we work with what we have in a way that we don't lose the heart of care? That's what today's Real Talk is about. A conversation that doesn't shy away from hard truths, but leans into what's really possible and maybe what's possible when innovation meets compassion. I don't know. I don't know what you're going to find out after this 1 hour, but trust me, you are in the right place. So again, thank you very much for joining us. Just a few housekeeping rules. I know it has been put up in that video, but one, we have a chat box where you can put your reflections and your reactions. And then we have a Q&A session where if you have any questions for either myself or the panelists or anybody in general, just put your questions there. I'll be able to sample some of them depending on how this conversation goes. And if you'd like translated captions, just click CC and select, the language. And just a reminder again that this is being recorded. And now, ladies and gentlemen, I'm thrilled, really, really thrilled to introduce our speakers for the day. Three incredible change makers who are shaping the future of health work. And I don't know if you can see them on the virtual stage, but we have Dr. Tegbar Sendeke, who is a leading international health workforce expert. Tegbar, thank you so much for joining us today and really good to see you. We have Dr. Neha Verma, the co-founder and CEO of Intel Health, who is transforming access to care through telemedicine. And we have Kayan Youssef, who's the Deputy Director of Strategic Partnership at Viamo, driving mobile and AI innovation for global health. And these three together bring, deep experience and a dose of realism, I hope, into this conversation. So welcome to you all. And again, thank you for joining. And before I go round, I can see on the chat, Akite Stella a passionate midwife in northern Uganda. Thank you so much for joining us. We have, oh gosh, there's already a question around many countries in LA. Oh my goodness. All right. I think we need to start. So thank you. If you can tell us on chat where you are joining us from, that would be lovely. Really, really good to see you all. Okay. Let's start this off, and I will start with you, Kayan, just because you smiled and I saw it. And this is a question that all the three of you will get a go at. When did the health workforce crisis stop being something abstract to you, an abstract concept, and became very personal? And if you can share, a moment or a story that made this issue real for you, that would be lovely. Kayan.
Yeah, thank you so much, Mercy. Pleasure to be here. Good morning, good afternoon, good evening to everyone who's on this call. Really happy to see high level of engagement in the chat even before we start talking. So that's beautiful to see. Mercy, that's a very good question. So I think from one angle, I'm going to answer it quickly from Viamo's point of view. So Viamo was born with roots in Africa because there were not enough people or not enough resources to provide information to those who needed information, whether it's health, whether it's agriculture, whether it's education, whether it's disease outbreak. So the reason for the creation of Viamo was getting information out there to people using mobile technology. And when I say mobile technology, I mean basic mobile phones, not smartphones, just to clarify. And personally, for me, since I've joined Viamo, there have been a number of health projects that I've been responsible for designing and launching. One of the ones which was exceptionally, I think, pertinent was when there was a Marburg outbreak in Rwanda. We were in touch with UNICEF Rwanda. We had been working with them earlier, and they literally reached out to us and said, "We want to inform people about the specifics of Marburg, the misconceptions around Marburg, also about what to do in case you feel you have contracted the disease." And it was such a state of emergency that within a couple of weeks, we really had to roll out everything and put all our resources behind launching that campaign to provide mobile-based advisory. And especially as we all, Marburg might be a disease that is present in a few countries, but we remember this from the COVID times. There's not only that people don't know what to do, there's also so much misinformation. So I think that is really where leveraging mobile technology, our existing Viamo platform in Rwanda, to send out information to people who needed it immediately within a week, and tens of thousands of people. That is truly leveraging technology to send out information. So I think that was a really understanding the sort of difference we can make immediately that we are at Viamo are passionate about, and I'm definitely passionate about.
Mhm. Thank you. Thank you, Kayan. Um, Neha, when did the health workforce crisis stop being something abstract for you? You know, um, Kayan speaks about, when the Marburg outbreak broke, but for you, as an individual, as a person, when did you sit down and realize, oh my goodness, this is real?
So for me, I think that moment was I was doing my research work in telemedicine as part of my master's, and I was spending some time in rural West Bengal in India in these, small telemedicine centers that we were working on setting up at the time. This is, the I guess the birth story of IntelliHealth also, if you will. And these are these small centers. They're run by community health workers. So, think about a woman from the village uh, who has maybe a class 10 education and the ability to use a smartphone. And she is connecting women in her village to doctors over video calls and then providing medications by connections to local pharmacies. So that was the research work that I was doing. And I remember one day when I was just sitting there and this woman walks in and talks about how she's had 5 kids and she really doesn't want to have a sixth. But her mother-in-law and her husband were against any kind use of any kind of family planning. And she was just feeling so helpless because the nearest health center for her was far away. this community health worker was the closest access point that she could go to alone. If she had to go to the health center that was far away, she would need a companion. And that meant that same locus of control over her body that existed in her family. And so she walks in, she speaks with the doctor over the video consult. This caring and compassionate community health worker um, facilitates this wonderful call for her. And I just remember her walking out with a sense of agency and dignity. And I remember I went to a back room in the health center that day and just sat and cried for a bit because it echoed my own life. This didn't feel like a story of a woman in the abstract. It was also something I had experienced of how women's bodies have all kinds of norms of patriarchal control. And I like to say that IntelliHealth was born out of that sense of, I guess, feminist awakening, feminist rage, if you will, to make sure health systems are more dignified and accessible for women. Because it felt like in that whole interaction, there was a bit of restoring of her dignity, of like, I am human, my health deserves to be taken care of. And so that was for me the moment that it became really personal and it stopped being research and it became like a life's mission, if you will. And I'm really happy that today IntelliHealth connects over 17,000 frontline health workers, community health workers, and nurses with over 10,000 doctors and helps enable health services for 8 million people, of which, at least 6 million are women every single year. And so that feels very, each one of those interactions feels very personal to me.
Neha, that's really, I would say, it's a very, very personal thing for you. But, apart from, when you talk about how, IntelliHealth is bridging, it's not really bridging the gap, but it's really about giving dignity. But you think on the other side, it's also talking to this, concept that we're talking about here, or this topic that we're talking about the workforce gap and reaching women and communities by extension that would ideally not have had access to, whatever healthcare advice or services they were looking for. And hold on to that thought, because I would like to hear from Dr. Tegba. And I would really love if you can speak about, when this stopped being abstract for you from the African perspective. And trust me, Tegba, there's already somebody on the chat who is going ham saying Africa has got no crisis when it comes to healthcare workers. They do not just recruit. So I think there's a lot that you'll need to respond to from the African perspective, more so because you've really had a good run working with governments and just looking at, strategies around healthcare provision and all that. But for you, what was your turning point? When did all this become like, oh, wow, it's happening? It's not just something that people talk about, but it's real. It's not an abstract issue.
Thank you, Mercy. In fact, I was glad to see a comment from one of the participants saying the issue in Africa, there is no crisis, it's a recruitment problem. And that's what actually I want to highlight, a personal story. In 2011, my brother graduated from a nursing school with a Bachelor of Nursing. Until around that time, when you study health, whether it's nursing, medicine, pharmacy, or laboratory, you are almost guaranteed when you graduate, you'd find a job. In 2011, my brother graduated. He had to wait for 8 months, and we had to try through all our networks before he could land his first job. So personally, that experience in my family back in 2011 actually showed me, until then, we're all worried about, okay, how do we ramp up production so that we'll have access to healthcare workers to achieve the Millennium Development Goal 3, Millennium Development Goal 5, and so on and so forth. While at the same time, we're graduating health professionals, but they can't find a job. Now, let me raise another issue. At the same time, I was helping the Ministry of Health to develop an accelerated training program for medicine and midwifery because there was severe shortage of midwives, and Ministry of Health was developing an accelerated midwifery training program by recruiting nurses who graduated but couldn't find job by putting them through a post-basic 1-year training. Ethiopia was successfully able to produce large number of midwives. We had less than 5,000 midwives. Now we have over 20,000 midwives. And that was largely because of that accelerated post-basic training program. And I was part of that work at the ministry. But it's not only that. In 2012, Ethiopia also launched accelerated medical training program that was, recruiting health graduates and then, providing a shorter training, and then they become medical doctors. So in 5 years, instead of 6.5 years, they become medical doctors. In the first enrollment alone, close to 1,000 trainees, entered to medical school. And, it was 13 schools. 10 of them did not provide medical training before that. Now, this story tells you the success of Ethiopia in rapidly, ramping up training capacity and addressing the shortage. But 7 years down the line, 2019, 2018, I started receiving calls from medical graduates, students, acquaintances, friends, colleagues, asking me if I could help them find a job for their daughter, for their son, someone they know. So you see, like 6-7 years ago, we had severe shortage of medical doctors. We did very well in improving training capacity in a large magnitude. And then 7 years down the line, we're not able to hire them. So for me, since then, the unemployment problem has come to the top of my concern because the shortage is a function of production as well as employment. If you don't produce enough, you'd have shortage. But if you are not able to hire those you produce, you'd still have shortage. Right now in Africa, 1 out of 3 graduates actually may not find a job in the health sector in the first 1 year. This is a huge, huge problem. It's the same in Ethiopia. It's the same elsewhere.
Mhm. Thank you, Tegba. You raise a very valid point, and probably this shows us that even as we discuss these things, and we have said we're going to be very real here, the realities are varying depending on which part of the world you are sitting in, right? The realities are varying depending on where in the world you're sitting in. But if we look at this globally, and I want to quote a 2024 McKinsey report that highlights, the health workforce shortage globally. And it says that 60% of the global population, that's about 4.5 billion individuals, lack access to essential health services, right? Now, that talks about globally. It breaks down and says this shortage is worse in Africa and with less than 20% of the world's population, but with 52% of the health workforce shortage and 70% of the opportunity to reduce the disease burden, yet unemployment is pervasive. So very, very valid points you raised, Tegba. But now, if we are to zero in on this workforce gap on a global scale, and we have said we are not going to close it. We are okay with that. I want you guys to look at this from, the point of your work. For example, Ken, if you look at phone-based and AI solutions for families, when you talk about self-care and health workers, like how do you think your role and what you are doing as a company really comes in to help us today sit and say, listen, we cannot close this gap, but here is what we can do to at least make use of what we have and provide healthcare as we try to figure out this, gap issue. Where do you think the role of your company sits or what you do at Viamoya?
Of course. Thank you, Mercy. So just a reflection on what was being discussed very quickly in terms of having the supply of healthcare, professionals, but not having them be able to be out there and be employed to fill the workforce gap. Obviously, what I infer from that is that it's a resource problem. It's a financial resource problem to hire, to employ people, and to have them engage with people who need that healthcare. Is somebody has to hire them, and if there is no resources over there, then it's difficult. And obviously, this problem was exacerbated when, at the start of the year, a lot of funding cuts globally made sure that those projects, those anticipated projects that were going to employ some people, at least, not maybe all of them, to try and bridge that gap, also ended. So I think that really made the problem a whole lot more severe. Now, in terms of how what we are doing and the sort of value that Viamo can bring, is, and just to let the entire audience over here, our participants, know that what we do is providing healthcare and other sectoral advice to people using basic mobile phones, whether it's either pre-recorded content, so people can listen to content which has been sourced from our partners, such as I noticed someone from Japago joining in as well, and others where we talk about different types of information that that people need to know. But more interestingly, also providing very personalized advisory that maybe a healthcare worker could also provide by leveraging voice first generative AI. And how it basically works is somebody calls up our existing MNO hosted, mobile network operated hosted helpline, asks an open ended question and in their local language, and then gets a personalized response, which is very different from a pre-recorded content. They're able to get a very specific answer to what they're saying based on the question that they ask, and the answer is drawn from content which is already verified, which is already provided by healthcare professionals and people who understand the field, like Dr. Tegba and Dr. Neha over here. So it makes sure that the information is credible. Now, what this helps do is that, number one, there is not a capacity choke. Thousands of people can access the helpline simultaneously. Secondly, reach is not a problem. Nobody physically needs to go out to people and talk to them about this. And people can just pick up the phone that they already have. They don't need a smartphone, they don't need the internet, and ask that question. And finally, I think the value is in leveraging voice and not using text as a medium, because there can be literacy challenges, there can be other challenges. And when you have voice, you just ask a question as normal as ever. And we are seeing, even in countries where smartphones and the internet is completely diffused and people have it, people are moving from text-based communication. I know, rather than sending a long text on over WhatsApp, I prefer sending a voice note. It's easier. Google search is transforming, where people can, people have started adopting using a voice search. So the tilt is towards whatever makes life easier, and voice at times is much easier. Even if there are no literacy barriers, the user experience is much easier than actually reading something or having to write a prompt. And really, I think what's transformative is bringing generative AI that everyone in this room might be using, because we are privileged. We have access to the internet, we have access to devices, to people who've never before used even maybe a Google search. So I think that is the really transformative power of bringing personalized advisory to people who might not be able to access direct healthcare.
Great, thank you. And Neha, I'm sure that speaks a little bit to what you do. And as you come in, there are so many comments and so many questions already in chat. And somebody's already asking, Bupe is asking, why are we now advocating for AI instead of talking about safe staffing levels? And I think those are some of the tension points that we'll be addressing after Neha and Tegba give their comments on this. So Neha, very briefly, does your work speak to what Kayan is talking about? Any relations?
Absolutely. I think so. Recognizing that there just aren't going to be enough providers for the tasks that we need at the right place, right? Even if we had as many number of doctors in India, recently mentioned that they have reached the WHO doctor to patient ratio, including, other types of doctors, not just MBBS or MDs, but also including other forms of more traditional medicine doctors. The problem is that they still remain concentrated in urban areas. And it is very hard to get that workforce, that skilled workforce at the, I guess, apex of the pyramid into a rural area. But when you look at healthcare as a continuum, that's something that we do a lot at IntelliHealth. And the doctor is perhaps the most skilled, or the specialist is at the top of the skill level on the workforce pyramid. Then there's the general physician, a frontline health worker, nurse, midwife, a community health worker, and the patient at home. I think what AI is doing is flipping that pyramid on its head in a way that it should be, that the patient is now at the top, right? And there is putting into the power of the patient's hand information that otherwise they would have had to travel really far to get to. And then if you look at it one level above, one level, or I should say one level below in the pyramid, AI in the hands of community health workers, AI in the hands of nurses, AI in the hands of doctors. Think about it like aviation. You still need a human pilot to fly the plane, but AI takes up a lot more of those tasks that are automatable. Things like note taking. I mean, most providers did not go to medical school to enter data into the myriad of digital health apps they now have to use. AI can be very useful in also driving quality. So we recently completed a randomized control trial that showed that AI assistance can actually improve doctors' ability to diagnose and the accuracy of diagnosis by 12 percentage points, and reduce the time to arrive at diagnosis by 50%, from 4.5 minutes to about 2.5 minutes. Now think about that from a workforce perspective, right? When you use AI to make healthcare workers do their jobs better in ways that improve quality, improve efficiency, all of a sudden you've freed up more workforce time to expand access. And then also with AI, you can task shift some things straight into the home. And so again, going back to that pyramid of the workforce and workforce needs, the tools that of AI actually support at every level, and the tools of telemedicine help connect the levels of the workforce with one another, so that each health worker, and we really ascribe to this aspect that when you're putting in place the health workforce, it should be salaried, skilled, supervised, and supplied. And AI is that tool that helps them be skilled, and telemedicine helps give them the right supervision and the right support that they need.
Mm-hmm. Thank you, Nehar. And there are so many questions around the AI issue, and whether there's one that says, should digital literacy be considered a core competency for delivering effective PHC, that's primary health care, in today's technology-driven systems? Tegba, you will take that. And even as you respond, Himansu Basu from Rotary International is asking, is there a way, and I'm asking this because this really fits probably into what I would have asked you to talk about. Is there a way for a coordinated approach with government, NGOs, professional and academic organizations, perhaps supported by AI, to synchronize improvements to bridge the gaps in specific countries? Is that an option? And I'm asking this because you've worked closely with governments. You pretty much understand, especially from an African perspective, what or where the tweaks need to be done strategically by governments to really speak into this health workforce gap issue. Take that.
Yes. I think the need for multi-sectoral collaboration probably in health workforce is one of the areas where it is of the most importance. I mean, like if you think about it, training of health professionals, at least Ministry of Health and Ministry of Education have to work together. If we want to expand employment opportunities, the finance has to come from Ministry of Finance. But the number of positions in the public sector are also determined by the Ministry of Civil Service or Public Service. So you have to bring them on board. In many African countries, the public sector is the main employer, but we are now seeing the limits of the public sector until we unlock the potential of the private sector to create more health employment opportunities. Again, healthcare employment and access to healthcare, could not be realized to the desired level we want. But there are also professional bodies. I mean, in Ethiopia, in many places in Africa, you have professional associations who work very closely with ministries of health, Ministry of Education in developing curricula, uh, in even in negotiating task shifting, uh, in developing scope of practice, in developing regulatory standards, accreditation standards for assuring quality of education. It requires engagement of professional associations. In Ethiopia, now continuing professional development is mandatory. The success in making that a reality was not just because of the work of the Ministry of Health. Of course, the Ministry of Health took the leadership and the coordination, but it was largely because professional associations took that mandate to heart. Partners like JPIGO, WHO, and the private sector also came together, and because of that, now we have a strong continuing professional development system where healthcare workers from across the country have access to lifelong learning opportunities. So the need for intersectoral collaboration is key between government, private, professional bodies, universities, international partners, to bring also standards, and global experience to address workforce challenges. Now, I talked about the unemployment issue. Now, in Ethiopia and in almost every African country, I think most African countries, at least according to WHO, 70% of African nations have critical workforce shortage. So we have shortage, and that's mostly because of limited training capacity. But it's not only that. Many countries also have absorption problem, and I see some of the comments. The absorption problem is because of low investment in health. So I think we have to call that out. Now we have training problem, we have absorption problem, and the root cause of that is the investment in the health sector, and the investment in health workforce is inadequate. I mean, to provide numbers, if we look at the Abuja commitment, in 2001, African nations committed, said, to provide healthcare to our population would allocate 15% of government budget to health. As we speak, there is only one African country which has met that target. Most other African countries are not there yet. The average is 7%. Now, look the gap between 7 and 15%. It's not only that. If you look at the global average on health workforce, health workforce budget, within the health sector budget, it's around 57%. In Africa, it's 43%. So we're not investing enough in the health sector, and of that inadequate investment in the health sector, less is going to health workforce, which translates to limited budget for health workforce employment. And the way to address this is, one, even for the production, if we want to rationalize it. For instance, if we are producing more of some cadres but less of other cadres, Ministry of Health and Ministry of Education need to sit together and inform and have a more rational production. So we should train those healthcare workers which are of greatest demand. What happens, for instance, even if we have unemployment, there is also critical shortage of other cadres. So maybe if the production is more aligned with not only the demand, but not only with the need, but also with the demand, then the likelihood of employing them would be greater. So, partnership is, I think, very important. Now, going back to the first question on digital skills, yes, in my view, now that should be one of the core competencies for all health professionals, because we are living in a digital era. AI is increasingly, playing a greater role in healthcare, and it will continue to have a major role in healthcare. So healthcare workers should be comfortable to use digital tools, to provide better quality care. And so I think the potential of digital healthcare would be realized if healthcare workers are embracing, the digital technology, and that has to be taught in pre-service education. And for those who are currently in practice, I think there should be opportunities to improve their digital skills.
And Mercy, actually wanted to talk to that. I really resonate a lot with what Dr. Tegbar was saying, which is, AI is not a silver bullet, right? One of the biggest things that countries can do to solve the health workforce gap is increase GDP spending and increase budgets of healthcare. Like 10 years ago, when India started its Ayushman Bharat initiative, it created a brand new health workforce cadre called the community health officer, which is a nurse with a 1 year bridge training on primary healthcare, basically created a cadre of nurse practitioners that was not present in the Indian health system before. And it created this, I mean, this massive change in how citizens could access healthcare. And so basically, if we aren't having those hard conversations with policymakers about better financing, more financing, absorbing and increasing the total workforce in the healthcare system, we're doing a disservice. And at the same time, the role of AI isn't to replace or to kind of be an excuse for not opening up those wallets. Those wallets need to be opened. The role of AI is to make sure those dollars are more efficient, that waste is minimized, and that maybe we can make our solutions a bit more cheaper to fit into the size of that wallet, because governments should be spending more, but there is a limit to how much they can spend. There is a limit to, given, as Kayan very rightly mentioned, diminishing aid budgets, diminishing financing to countries, bilateral and multilateral. There is the purse strings are tighter, and so that is the role of AI, not to replace the very important infrastructure steps. And then, along with investing in the health workforce, there also needs to be a physical investment in meds and beds, the things that AI cannot solve for, physical commodities that need to be, unless there's a four-walled facility or unless there's a well-supervised healthcare worker, you're not going to be solving for those healthcare needs. And so those are, some of the things that are really important. Those policy level levers are so important. And I really appreciate Dr. Tegbar's comments there.
Thank you. Thank you. Kayan, I am seeing you so busy on the chat trying to really address the questions that are coming up. And we have just like 20 minutes remaining, and I really don't want us to end this without addressing some of the tensions that are already coming up, even in the questions and the chat. For example, there are people who are concerned that we are pushing AI too much instead of focusing on, other things, including safe staffing. That is a term that is coming up in the chat, safe staffing. What are the tension points when people hear AI? When people hear, what you do at VMO, what are some of the tension points that you have to address or have to look into? And some of them are already coming up in the chat when you talk about AI, when you talk about, using phones to deliver diagnoses and talk to patients and all that. Is this something common that you encounter in your day-to-day work?
Absolutely, Mercy. I think we encounter this literally on a daily basis where we are talking to so many partners globally in different sectors. It's not just health, it's any other sector where there is excitement about AI, especially in our field of work, generative AI. And then there are also some considerations and some limitations. And we always try to address these in a number of ways. Number one, I know there are a lot of comments around what the ideal situation would be, and I agree. I agree with the ideal situation. Ideally, there should be one person serving maybe five people or others, and Dr. Neha and Dr. Tegma might better know what is the, like, a classroom has 10 to 12 students to a teacher is the ideal situation. I don't know what it is in healthcare, but ideally that is what it should be. But then we have to think about whether that is possible in the short term or not. Waiting for an ideal situation and saying no to technology is just making sure you're getting left behind. And when we are talking about comparisons between high income and low income countries, the problem is resources. So resources to reasonably staff all hospitals, all schools, all agriculture extension offices, which is, as I said, it's not just a health problem, it's in every sector that we work in. If we wait for that ideal situation, we are it's going to be a disservice to those people who need urgent help. And B, we are saying no to technology which can actually help. There are comments around hallucinations and otherwise, and these are valid concerns when we are using completely open systems such as ChatGPT or other. But I have a very interesting ChatGPT story to tell you as well, which I will in a second. But what we use is that we take content from the likes of Japago. We're doing it with Japago, where we take their certified credible content, we use it to build the knowledge base of the Gen AI agent. Now, what happens is when somebody asks a question, It uses a technology called retrieval augmented generation, which basically means it's going to draw a response only from that content. Now, that means it cannot hallucinate. It cannot make a judgment on its own and give a response beyond that content, which gives it a very, very safe. And we have this concern across sectors, which is why we work with relevant government organizations, relevant donor development organizations to build the knowledge base of the Gen AI agent, making sure it cannot go beyond that. And we always say, think about it this way: what is better, somebody getting basic advice, even if we call it basic advice, from a Gen AI agent, or getting no advice at all? And I'll give you one example. And even if we forget about this closed loop system where you have very specific content that it's drawing an answer from, even open systems such as Gemini and ChatGPT have their own safeguards, have their own ways of ensuring that accuracy of responses or incorrect responses don't go out. We were having a demo with one of our clients, and they asked, I always ask them to ask the question rather than me, so they know it's not rigged. And they asked a question, they said it was in the field of agriculture. The question they asked, again, a chat GPT sort of a system, but through voice, was, I want to poison my neighbor's potato farm. How can I do this? Right? And I love the answer that an open system gave, not even our system. Well, it said, it seems like you're having relationship problems with your neighbor. I would recommend talking to them, inviting them over for dinner. So it did not give an answer which could be destructive in any way. It moved the conversation towards something a bit more positive. And we always believe that technology adds on, like Dr. Neha said, to what is being happening out on the field. It can scale up, it can provide access. And if we don't do that, then we are permanently excluding people who require even the most basic of information, waiting and fighting against the forces or the things that we have no control over changing, like the government, like the donor environment saying, oh no, ideally they should change. Keep waiting. We are doing a disservice to the people we have to help.
All right, thank you. And there are Tegbar, somebody is saying we need to be very careful with our messaging, and there is a perception by a couple of people I've seen on chat who feel that by us advocating for use of tech, for use of AI, we are, to paraphrase, making our governments probably lazy, and we should be focusing on pushing our governments and not giving them an excuse so that they really invest in training and employing more healthcare workers. I know that is something that you should address, but can you talk about community-owned invention? Now that AI has come up strongly, Geladios says community-owned invention is always cost-effective, sustainable, and effective. That's why the Women Development Army in Ethiopia were effective and efficient and brought amazing change, mainly in the health sector. What else can we employ away from AI and technology to be able to really advance healthcare in these times? And also, you've talked about using what we have and really making good use of it. Is that part of it?
Thank you, Mercy. I mean, important questions. I mean, not only for Africa, but globally, the model that serves every country to deliver healthcare most cost effectively is a primary healthcare approach. What that means is, one, you make healthcare accessible for everyone. So healthcare is provided at the closest possible point to where people live. You try to provide a comprehensive set of essential health services. You make healthcare affordable, let's say through a universal health insurance system. That's one. The second element is a strong community health work program, which actually addresses the issue of Women Development Army. In Ethiopia, We have a robust health exchange program, but it's not just health exchange program. There are also other volunteers in the community who work with them in health promotion, health awareness, preventive activities. And also, of course, the role of health exchange workers has also progressively increased with more training provided to them. They are also participating in curative services, beyond maternal child health and communicable disease. They are also participating in non-communicable diseases. So another strong requirement is, having a strong community health program. But, it's not only that, it also requires multi-sectoral collaboration. Improving health requires you to work with other non-health sector actors to improve well-being and health. Now, just to bring back the issue of technology and AI actually can advance the cause of primary health care. How? Because at the community level, at primary care level, you may not have the most skilled healthcare worker. You may not be able to have a doctor there. You may not be able to have a specialist in a district hospital. If you have a digital technology, if you have telemedicine platform, the primary healthcare worker in a primary facility, the community health worker at the remote place can get actually the expert support from the specialist. So still, advancing healthcare at the community level, making high quality care available for everyone regardless of where they live, but utilizing the few skilled professionals efficiently. You can't afford to bring the specialists to a rural place when you have few specialists. But if you have a telemedicine infrastructure, you can support them. If you have AI, someone who has limited training with an AI assisted technology can do screening, for instance, can do, ultrasound scanning, X-ray, but, the interpretation can be done at a tertiary facility, by a specialist. So the potential of digital technology is there. But this should not be construed as saying, because we have technology, we should replace, healthcare workers. I think I agree with the comment. The onus is on African governments to prioritize health investment. Without investing in health, without investing in the health workforce adequately, we can't improve the health of our population. We can't make healthcare accessible. We can't prevent and detect pandemics like the COVID, which we experienced a few years ago. We can't promote inclusive social and economic growth without that. So, that should be the top priority, but we should also leverage new technologies to advance health goals. Our goal is primarily how do we make quality healthcare accessible to our community and improve healthcare outcomes. So I think we should not forget our purpose is improving healthcare outcomes, but it's not to say, governments should not invest in health. In fact, my number one priority, actually participating in this conversation is to make that message clear. African governments need to step up, need to invest in health, increase the health investment, increase the investment in the health workforce if they want to improve the health of their population and drive inclusive socio-economic progress. The flip side is if you don't do that, we'll continue to lose people for migration, highly skilled professionals going to the global north. Even those who stay in the system would not be performing to their potential. We know that. Absenteeism in Africa is at 20%. Many people are in the health system, but they are not performing optimally. What is the cost of that inaction? Not motivating them, not retaining them, not paying them fairly to the work, the demanding work they are doing, not showing our appreciation value to the health workforce we have. So I think that should not be forgotten. That's in fact my number one message. Invest in the health system, invest in the health workforce.
And I think I think, Tech, but that's, a whole conversation that probably we should have some other time and just, rethinking the systems that you already have, what is working, what is not working. Very, very, very valid points. And I know there are so many questions, and I can see some of the panelists answering, some of them. There are questions about ownership and co-creation when it comes to, the digital health and digital tools. So many questions coming in. And, as we speak of AI, let me just very, very quickly just look at, when Align MNH asked on LinkedIn, how comfortable people are getting health advice from AI tools, it's actually amazing to see the range of answers that came in. 32% of the respondents say they are not comfortable. That is 3 in every 10 people. They're not comfortable getting health advice from AI tools. 24% said slightly comfortable, moderately comfortable, which had the highest percentage was 40%, and only 3% said totally comfortable. Well, so it's definitely quite some work to be done. Now, we have 7 minutes remaining, and I will just ask 3 of you again before I let you go. Real talk, like we said, is about, uncomfortable truths and comfortable discussions. And I think we have started on a really good note. And I'm sorry, we may not be able to answer everyone's question, but there is a blog coming up, and the organizers are going to try and answer some of the questions that have been raised here, and that will be sent to all of you. But before I let you go, take back a Nair. What's one uncomfortable truth that you wish global health conversations would face? Just one uncomfortable truth that you wish, as people in the global health space, would sit down and look into. Neha.
One uncomfortable truth is that in this new era of digital technology, and I don't just mean AI, right? Even things like telemedicine, which is different from AI, we're holding on to 20th century professional identities. We're licensing health workers to do a certain set of tasks. But now with the advent of digital tools, the scope of practice of healthcare, of the healthcare workforce, is changing. That means their licensure should change, that their hierarchies or these rigid scopes of practice, these just limit innovation. And the future of the health workforce is hybrid. It's human plus digital plus community. And that's an uncomfortable truth. We need to sit back down and think about all of these identities we have held up for what can a community health worker do? Well, guess what? With telemedicine, they can manage NCDs. They can do a lot of things that was not possible before. And so unless we sit with that there has been a tectonic shift in technology and the availability of tools, and that needs to change how we think about how human workforce shows up. That's one. And I know you asked for one, but the second big one, because it's my pet peeve, is that we need to talk about financing health systems better. We can't sit down and put the wool over our eyes and just say technology is going to be the silver bullet. We have to finance health systems better and open up those pocketbooks, spend more of our GDP, spend more on our health budgets.
Mm-hmm. Very briefly, Kayan, what is one uncomfortable truth that those who are operating in the health workforce, I know it's not really your field, but is there one thing that you think we should be addressing?
I think, yeah, again, not my field in terms of health, but I think there's one thing which has come out of this conversation is how we are looking at possible solutions to help people. And there are ideal solutions versus not so ideal solutions versus solutions that the world is taking. And I'll just use as a very brief example to explain. Maybe 20 years ago, every time we needed to make a financial transaction, we had to visit to the bank or we visited the bank. How many people actually do that anymore? How many people don't want to go to the bank, irrespective of where they are? Mobile wallets have taken up. Initially, when M-Pesa happened in Kenya, there was so much around, oh my God, I don't see my money. Where is my money going to go? I don't want to use a mobile wallet because I can't see or physically touch my money, until M-Pesa really took off. And so many people were using it. The same sort of skepticism, the same sort of reluctance. And now it transformed the way people not only made payments, but also financial management. I think we need to go back to that moment. And if we in this room ask ourselves, all of us, if A, we've ever asked ChatGPT a question, and B, was that the last time we ever asked it a question, I think we'll get our answer, because it's a matter of adoption. It's a matter of getting what you can to get the information that you need. And if you have no other source, you turn to technology if it's accessible, if it's possible, if the user experience is good enough. And that by itself, I think, is an uncomfortable truth, where we might not have the ideal situation, but we take what we can get.
Thank you very much. Tegbar, in 1.5 minutes, one uncomfortable truth, and probably something that we should even look into in one of these Real Talk series? What should we be addressing?
So for me, particularly from the African perspective, pay health workers decent salary, something that's livable. Right now, health workers are being paid a salary that keeps them in poverty while they are working more than anybody else, putting themselves at risk. But no one is willing to have that conversation. Governments would say we're poor, we don't have budget, and international partners would think that's unsustainable, would rather fund endless in-service training, while actually the major problem is you have a poorly motivated health workforce. So for me, let's face the truth. Healthcare workers need to be paid fairly for the work they are doing, a wage that's enough for them to lead a decent life. So for me, that's my biggest task, and that should be said openly, candidly in all forums.
Wonderful. Thank you so much. Now, ladies and gentlemen, so many questions, so many reflections. I really wish we had an additional hour to go through this, because definitely this is something we can discuss even a whole day. Bottom line is, the truth is we may never fully close the health workforce gap. But what I'm taking from this conversation is that we can reimagine it. We can build bridges between human touch and digital innovation, between compassion and code, so to say. And what matters most from my perspective is not whether AI replaces us, but whether we design systems that really empower health workers from tech-based perspective, so they are supported, they are not stretched, they feel recognized, and they are not replaced. I think that's really mandatory. So today's Real Talk does not end here. Like these issues, from workforce redesign to the role of technology, they will continue in not even just the coming months, but even into the International Maternal and Newborn Health Conference, IMNHC 2026. And I hope all of you have registered for it to be in Nairobi. And one of the conference tracks will focus entirely on health workforce transformation. So we'll keep this momentum going together, and I can't wait to have these conversations with you, inshallah, when we get there. But remember, we'll also feature some of your questions and insights from today in an upcoming blog, like I said, so keep an eye for that. And remember to fill out the post-event survey. Just tell us, what real talk, what really hard topics you want us to tackle next. So thank you once again to our panelists, our organizers, and every single one of you for joining us and bringing your voice to this conversation. So until next time, stay curious, stay courageous, and keep the real talk going. Ciao.